All right, welcome everyone. I'm Rachel Patzer. I'm chairing this conference and I'm introducing, very excited to introduce our speaker for today. This is the Lunch Symposium, Navigating C3G in Transplantation, Addressing Unmet Needs and Managing Recurrence, a case-based discussion. Thank you to Apellis for sponsoring this event, and on behalf of the AST, I'd really like to support Apellis for their support of the CEOP meeting. So I'm excited to welcome our speaker, Dr. Vanita Kumar, who is a professor in the University of Alabama, Birmingham, and the medical director of the UAB Incompatible Solid Organ Transplant Program.
All right. Good afternoon, everybody. Thank you for being here. I'm going to start by saying there are probably a lot of you who are experts in this topic and know as much as I do here. So this is going to be something that we're going to work and talk together. Always say I'm not the sage on the stage. I'm just the guide on the side here for this endeavor today. Here are my list of disclosures. Don't let that complicated slide fool you. I'm an extremely simple, unimportant person. But I'm a rule follower, and I have OCD, so everything that could potentially be interpreted as a conflict of interest is up there, and that's my 6 seconds. For every conflict of interest slide, you have to have it up for 6 seconds if you really are going to do justice to it. So with that said, most of us don't think about C3GN on a daily basis. And if we do, if it's because we've had a case. And when you have a case, it can be all-consuming. And today, I would like to work with you on a case that we had at our institution. And I want your help in reflecting at every decision point, is this what you would do or should do if you happen to have this case or have had a similar case? And then let's see how everything panned out in the end. So with that said, here's a one-liner. This is the one-liner that our nurse practitioner, when she was presenting the case, came and said, this is a Caucasian male, young, 36, and has C3GN as a cause of his ESRD, and he's here for evaluation for kidney transplantation. So my first question to you in the audience is, how many of you in this past year have worked up a case of C3GN? 1, 2, 3, 4, 5. Keep the hands up. 6. 6 of you. That's fantastic. That's more than I thought. And if I said last 2 years, do we have more hands? Okay. So now we have about 8, 9 maybe. All right. So in thinking about a patient with C3GN, if this patient is otherwise found to be a suitable candidate, what are some things that you consider just by virtue of them having C3GN in their workup? How would this patient be any different from somebody else who had IgA or PKD or ESRD of unclear etiology or ESRD secondary to diabetes? Anybody? And then we have people who can run around with the mic. Not people, Jean Young and Sam, thank you. So Dr. True says risk of recurrence. That's something I'm sorry? The etiology and risk of recurrence. Yeah, so because they have C3G and you're saying you would worry about the risk of recurrence. Yeah, absolutely. Other considerations? In your evaluation or workup, would you do anything differently because they have C3GN? Yeah, Dr. Singh, yeah, I've got a couple of hands there, this table and then the table in the back. Yes, please. So their history of what treatment they've received for their C3GN so far, yes, absolutely, yep. And I think that on the same table, there was another hand there. Thank you,
just to
Jean
see if there are any living donors coming forward, do we need to be careful or whatnot? You know?
Can you repeat that? I'm so sorry.
If any living donors are coming forward, then
are there any living donors coming forward?
Special considerations.
Okay, all right, time to transplantation, absolutely. Dr. Singh had a hand up here. Thank you, Jean Young.
I guess rule out any secondary etiology. I think Dr. was mentioning that, right? Could be any
Absolutely. Rule out infections or polyclonal gammopathy or monoclonal gammopathy as a secondary cause of their C3G. And absolutely. So I think you've answered most of the considerations. So what would now if I asked you more deliberately, these are all potential considerations, but what would your primary, if you had to pick one, what would your primary concern with this patient be as you consider them for transplantation? I guess this is Slido, but if you're eating and you don't want to pull out your Slido, that's fine. Let's just start with show of hands. Disease recurrence post-transplant. A lot of hands. Okay, how about graft loss? A few. Okay, how about this is too complicated at our center and we wouldn't take this patient for transplantation? Okay, everybody would, all right? No concerns? All right, good. And any concerns that we haven't actually already voiced? Anybody else nibbling on something that they're thinking that that should also be on the table? Yes, please, there are two hands up there. Sam? Yeah. Familial and donor consideration. So if there's anybody in the family who steps forward, would you then consider them as potential living donors because of this condition? Thank you, yes. Anne? Yeah, so if you are going to transplant them and if they need any therapies, will insurance companies approve therapies since there's not FDA approval for some therapies? So these are absolutely legit considerations and they kind of go hand in hand with risk of recurrence or should we transplant or not? Absolutely. All right, great. So let's actually see what happened. So this patient, this was back in 2022. He's young. He was 34 then, he's 36 now. We're evaluating him today, or in last year is when we evaluated him. And essentially, this young person was just going about their life and had just started their own IT consulting firm and had been working incredible hours and was like fatigued and tired and, we all put it down to, I've just not slept enough, I've been doing too much. And then he started having URI-like symptoms and then bad body aches. And finally, his wife is, you're going to go in because today you didn't even get out of bed. This is not like you at all. So he goes in and gets seen by a primary physician who gets some labs. And lo and behold, has a creatinine of 7.8. And 2 years prior, when he was actually in another job before he started his ID consulting, his creatinine was normal, so this was new. His UA did have blood and protein, and he also at that time on lab had extremely elevated LDL and also was diagnosed with hypertension. So that primary care physician sends him to a local nephrologist. This is in another state, and he ends up getting a biopsy. How many of you would like to see what the biopsy showed or what the results were? Yeah? Okay. So this patient comes for evaluation, right, to clinic. And then now we want the results of the biopsy. So the patient now is not in clinic. We get the biopsy results, and this is what we get. It's a lot, right? So this is now something that, as we think about managing patients and managing care, and as you're sitting in clinic or sitting in your office and you're getting records to review, this is what you get. Something facts that's then scanned in. Thank goodness for our coordinators who get all this information for us. We still have to distill it down. But since we're in a talk, we're going to make it simpler. Actually, just type that all up into a slide. And then the diagnosis here is C3 glomerulopathy. And this is an incredibly well-read biopsy. It's been read at a very good center by an excellent pathologist, and it's evident in what's there. In yellow are all the light microscopy findings. So there are 45 gloms, so fantastic biopsy. Unfortunately, 33 or over 60% of the gloms are gone. They're not working. And then the interstitium is pretty short. 70% of it is gone. So this is a pretty far gone biopsy. And the one-liner is that it was diagnostic of C3 glomerulopathy, but what makes it C3 glomerulopathy was this MPGN, or membranoproliferative pattern of injury, with these rare double contours. We're used to seeing that. And interestingly, 5 of those gloms, so 12 surviving gloms, 5 of them had endocapillary hypercellularity, and 1 had a cellular crescent. So that's your light microscopy. On immunofluorescence, there's C3 dominant diffuse staining. So it's diffuse and global. So all gloms and all the functioning gloms and the full glom has C3 dominant staining. And on immune EM, there's also presence of large intramembranous deposits. There were some mesangial and subendothelial deposits too. So that's the biopsy read, and we're like, okay, we want to see the actual images. These are the images that we get, and we tried to get these images a few times, and the faxes came through like that. We eventually were able to get the actual block and look through it. But now, in evaluating a patient, look at all the number of steps it takes. This is more academic interest. At the end of the day, this kidney is shot. He had a presenting creatinine of 7.8, but we needed to know what we were dealing with. So the MPGN pattern, so let's unpack what we saw on the actual biopsy read. On the right of the screen is what a normal renal cortex looks like. You know, tubules are all back to back. Most of the tubules are closed. Some may be open, some artifact preservation. The gloms have pretty open capillary loops. You know, the typical thing we're taught, 2 to 3 mesangial cells per tuft. This is all nephrology lingo. And then on the right-hand side, when you see that, let me see if I can have the pointer come up. Yep. What is this pattern called when we see MPGN, but these little lobules? Yeah, absolutely, lobulated MPGN, right? So this lobulated pattern of injury is what we call MPGN pattern, but that's not what makes this C3GN, right? Through my time in nephrology, I went through classification of MPGN when it was MPGN 1, 2, and 3, and I was like, okay, which one was which? Where are the deposit? What makes it 1? What makes it 2? What makes it 3? Eventually, it was reclassified about 15 years ago, 14 years ago in 2011, based on immunofluorescence. So now MPGN pattern of injury that you saw on light microscopy now gets further divided based on immunofluorescence into what actual disease, well, what actual phenotype of MPGN it could be, and how does immunofluorescence help us? So in the top, here is MPGN, and in MPGN, we have not only C3 staining, we also have immunoglobulin staining, and it's a codominant process of both C3 and immunoglobulin, so immune complex MPGN versus a C3GN, which is either C3 alone, or even if it has immunoglobulin, the C3 staining is at least 2 times more intense than the immunoglobulin stain. That's sort of what differentiates an MPGN pattern of injury into immune complex versus C3GN. So here I pause and ask you guys, why is it important to differentiate the two? Why is there immunoglobulin deposit in an immune complex MPGN versus not so in a C3GN? Anybody? So the rule in any time in doing any kind of talk and pause is you have to wait 6 seconds. And then after you wait the 6 seconds, there's actually a few people who are already thinking about the answer, but they're not fully sure. I would be one of them. I wouldn't be the one to shoot up my hand and say, but if you're thinking that most diseases that cause immune complex MPGN are diseases that are driven by infections, like hepatitis C, you need immunoglobulins along with the complements to cause that kind of injury in the kidney, versus something that's pure C3, that's just a complement. Exactly. Yes, you guys knew it. It's a complement dysfunction. That's why that staining pattern looks like that. Okay, so now we know this is some sort of C3GN, and then We started at MPG and pattern of injury, separated it into immune complex versus C3. We know now that it's some sort of C3GN. And then what separates a dense deposit from C3GN is essentially where the deposits are on electron microscopy. In dense deposit, it's just in the basement membrane. They're thick, dense deposits. And if it's C3GN, you can have deposits in other areas. Interestingly, Dr. Fogo, Agnes Fogo, read this, and I had a conversation with her, and she said this is a very difficult one to tease out. If you really make me commit, I might say C3GN, because I'm seeing a few mesangial deposits, but it looks like an evolving dense deposit. So treat this very seriously is what was the bottom line that we got out of it. So for those of you who are interested in looking at the EM on this one, this is sort of the normal renal tissue. This is the dense deposit where there you can see these certain areas of the basement membrane have these thickened deposits. And if it was C3GN, it's not just basement membrane, but mesangial also. So what we now know so far is this is not just primary type 1 immune complex MPGN. There were no subepithelial humps, so it's not post-infectious. And this is most likely C3GN. I put here not dense deposit disease, but you have to treat it as, you know, potentially evolving dense deposit disease, but at least at this point it's C3GN. And why does it matter if this is C3GN? It's because most patients with C3GN at 50% at 5 years or 5 to 10 years end up on ESRD. But what is really fascinating is the risk factors for native kidney disease that end up with ESRD. And the risk factors, every one of them applies to him. Age at diagnosis, so the average age or the median age at diagnosis is about 28 years. He was 34. If you're younger and have C3GN, more likely to go to ESRD. If you have low GFR at presentation, his creatinine was 7.8. If you have crescents, yep, check, check, check. And then if there's dense deposit disease. So he had all the risk factors for progressing to ESRD at presentation. Somebody who was otherwise walking around healthy and just sort of out of the blue. All right, so this is all still happening in the past. We're evaluating this patient. We're gathering data on this patient. And where do we come to? All his medical evaluation is turning out to be okay. He was not insured at that point because he was self-employed and owned his own IT consulting business and had discontinuous care when he presented with a creatinine of 7.8. He moved from Tennessee to Alabama. He presented to our emergency room late 2022 when he needed to start urgent dialysis. And then once he was placed on dialysis, he moved out back into the community to a dialysis facility closer to where he lived. His life events stabilized. He got medical insurance. He was here with us seeking evaluation. And at evaluation, his wife, his parents, and his in-laws all were there with him. Terrific support system. Each one of them has said, test me, take me, I want to be a living donor. So with that background, what additional information do we need? You guys already alluded to it. He had already been tested with the usual infectious workup, the usual HIV, Hep B, Hep C, lupus, all the rheumatologic conditions we think about, which incidentally immune complex GN is very closely associated with, and C3 is not, but for whatever it's worth. Dr. Singh, you asked for monoclonal gammopathy, so that's the result of the monoclonal gammopathy. If we are looking to see a M spike in the gamma region, his was completely normal. He did not have that M spike. And his serum free light chain ratio was normal, and his immunofixation beautiful, so that's not an issue. Now, he presented in 2022. He's on dialysis in 2023. We're testing him in 2023, and his complement C3 level in 2023 when he's in dialysis is still pretty low. Normal being 90 to 180, he's at 51 milligrams per deciliter. That's worrisome. There's some activity going on there. Then the next thing people say is they want complement system functional and genetic testing. It's an obvious question, but I'm going to ask you the obvious question. Why do we need this? What does it matter? If we want to transplant him or we don't want to transplant him, how does this change our decision tree, having this information? Yes, Dr. Akalov.
You can use eculizumab preemptively during transplant as an induction
So you're
to prevent
saying,
recurrence.
so you're saying if you had the information, somehow that would inform your decision of using eculizumab.
Yes, and if
Okay.
there's a nephritic factor, that may also change my thinking
Okay.
a little bit too.
Yeah. All right. What else? Considering his donor, so if he had a genetic dysfunction, genetic predisposition, then what was brought up earlier about whether you should use those donors or not, if there's a family history. Okay. Yeah. How many of you would do genetic or functional testing at this point? About 10, 12 of you? Okay. Well, we chose to do it. And so why do we choose to do it? For every, there has to be some reason for the method to the madness. And the reason we chose to do this is because if this is C3GN, we wanted to know if this was still very active. The C3 level was really low, but what was driving it and what else was going on here? And so this was something that we had to all educate ourselves as a group. And what was very fascinating to learn in the early days of C3GN is that while the classical and lectin pathway requires some sort of trigger, a specific trigger like autoantibody or pathogen-associated molecular patterns, the alternative pathway under everyday conditions is always on. It's called the stick-over process, and essentially what it is that this continuous activity at a low level, because of this tick-over process, which refers to the spontaneous hydrolysis of C3 in the bloodstream. And the reason that is there, even in normal circumstances, why we always have some degree of C3 circulating, is because it's an army there at low level. In case there is invasion, you can quickly amp up and amplify that loop. I can't get this to move. Okay, yeah. Amplify the loop, and then the C3 now can get the distal complement pathway to get activated. And in C3GN patients, this alternative pathway is on even more so, not just at the low level that you and I have, it's in a persistent overdrive. And what is fascinating to me is if that's the case and that's how injury happens, why did it take him to be 36 years for him to have kidney problems? And what other things happen when you have this persistently activated syndrome? And apparently macular degeneration is something that happens, or lipodystrophies, another acquired lipodystrophies, another manifestation of some of these diseases. So here's his functional complement testing result. Yeah? All the gray stuff is abnormal, and if you're squinting, well, let's make it easy. This is his actual result. I'm going to give you a moment to just look at all the abnormal things up there. So C3 levels are low. All the C3, C5, and C4 NeFs, all of them are present in his system. Even today, a year and a half after his initial presentation. Factor D and BA levels are present, abnormal, elevated. And then the terminal complement complex, the C5b9, is also there, low level, but there, suggesting the entire cascade is on. So let's sort of break down the results together. Factor B and D levels that are abnormal, well, it turns out that factor B, A, and D are consistent with renal insufficiency. Those are the major, kidney is the major site where these are go through a catabolic reduction, and if you have advanced dysfunction, you're on dialysis, those levels can be elevated and are not interpretable even in the right circumstances. So you can't do much with that. We already set the C5b9 levels are mildly elevated, okay? So there's some ongoing dysregulation. Let's look at the NeFs. All the NeFs are elevated. Let's look at C3 NeF. C3 NeF, what's the job of C3 nephritic factor? Well, it stabilizes C3 convertase. Well, what is C3 convertase? Well, C3 convertase is what is on in patients with C3GN. It's also what is activated when your alternate pathway gets activated, or if your classical and lectin pathway gets activated, to get the cascade going at C3 to get the two split products. And the job of C3 then, when that gets activated, is to consume the C3, create the split product, C3A, which causes inflammation, and the C3B is part of now breaking down C5 into its specific patterns, and also goes and joins C3 convertase. So when you have infection or some sort of pathologic onslaught, your C3 convertase level gets revved up, and then when that onslaught is gone, it should be gone, or get back to that low level takeover. But it doesn't in patients with C3GN because they have the C3 nephritic factor that stabilizes C3 convertase and say, hey, buddy, don't go, hang out, keep doing the damage, even if there's no reason to do damage. And this patient now has continuous ongoing activation of his entire complement cascade, including having some MAC activation. All right. Then it's a lot to go through. Should I pause for a moment? Should we discuss any of that for a bit? Okay. All right. Genetic testing. He undergoes genetic testing, and the genetic testing, I've highlighted the results. There's no plausible single nucleotide genetic variant identified. He did have a heterozygous deletion in the CFHR3, CFHR1, but it's a very common variant even in the general population, and it's not associated, it's not a pathogenic, especially if it's heterozygous, but even if it was homozygous. So interestingly, the C3GN data actually says that most of them are not associated with the genetic driver. So why some people have the C3 convertase activity with the C3 NeFs, basically C3 NeF is an autoantibody, so why some people have that, who knows? And why this disease manifests when it does, who knows? And what turns it off? Well, I should not say who knows. Somebody knows. People who are studying the complement system knows. But for clinicians like me and many of you who are taking care of patients, if you have to explain this to patients, don't have answers. All we know is this is what's going on. And the composite results of the complement genetic testing is there's ongoing NeF-driven dysregulation at the C3 convertase level as indicated by C3. There is dysregulation at C5 level too, although it's minimal as the C5b9 levels are borderline. So what the case summary so far is, this is a patient who's 36, had crescentic C3GN that caused RPGN in his native kidneys, now on dialysis at rapid progression. He has evidence of ongoing functional complement dysfunction. He desperately wants a kidney transplant. He's otherwise acceptable. And if not for all of this, he's approved for kidney transplantation. He has the potential donors. What do we do next? Knowing all this, how many in the audience would transplant him? Show of hands. Okay. How many of you would not transplant him? And how many of you be anxious transplanting him? Okay, that's a bigger category. Right? That's not a fair question, but even the ones who said they would transplant him are anxious, so you get that. So that's probably not a fair question. Okay, what brings on the anxiety? Recurrence. How? Recurrence and ultimately? Ability to control it, avoid it, and graft loss, right? So absolutely, all of you. So what's the risk of recurrence? We talked about the risk of ESRD progression. Now I've got to sit down and talk to this patient and his donor and his family about risk of recurrence, right? What is the risk of recurrence here? Yes, Dr. Gaston. Ah. So your question, no, it's a great question. It's not coming, so we should talk about it. Was this patient treated? And you had asked earlier, Dr. Abidi, is that right? About what his past treatment was. Because he presented so late in the game with 70% fibrosis, creatinine is 7.8, and low GFR, he was not treated back then. So that. Exactly. Response to therapy with native disease is not something we can lean on here. Absolutely. There's some other hands I saw up there. Did we miss? Yes, Dr. Jane. Oh, if you have to use, okay, so you're already like saying if we're going to transplant him, we'll have to use something. That something could be some complement modifier inhibitor, and then what are the risks of infections associated with it? Absolutely. Yes, Dr. Doshi.
Oh, thank you.
Yes, vaccinations to absolutely, if we're going to use complement inhibitors, we have to consider the possibility of vaccination. And, this sort of makes me really pause because, say, in our clinic, because we have a pathway, we know how to order vaccines beforehand, the Menectra, the Boxera, we have Menfiquad now, and we have them available. We can order it when the patient comes. But if it's not something that's set up, or if you're in a primary nephrologist standalone office, how do you organize that? You have to send them to like a local health department or something. These are real considerations that we absolutely need to be talking about because these inform our decisions of how we're going to manage our patients. Absolutely. Other hands? Yes, Dr. Akalov.
This patient having C3 NeF, C4 NeF, and C5 NeF, does that change how you approach this patient?
Great question. This patient has all the NeFs, so would that change how we would manage him? Yeah. Would anybody like to answer that question? It's a really good question. The real answer is we don't know. But if this patient is sitting in front of us, and we have to figure out a way to help him, part of helping him is admitting that we don't know, but we'll do what we can to help you. Yeah. All right. So we'll get to the likelihood of recurrence. Let's just first say that, I'll give you the numbers in a bit, but the likelihood of recurrence in patients with kidney transplantation with C3GN, at 1 year, it's pretty good. I actually have to look at my numbers here because I wrote 94%, so it's not bad. By 5 years, it's 67%. And by 10 years, 25. This is graft loss, sorry. So 25%, survival, 25. At 10 years, only 25% of those grafts are surviving. So graft loss is a huge thing. Recurrence is huge, 89, but graft loss is huge with these patients too. And the reason being that if you transplanted them, that doesn't take care of whatever this complement dysfunction is happening. The other part of it is, do you guys know what the risk factors for recurrence are after kidney transplantation? Low C3, absolutely. Yes, Dr. Doshi. There are two other ones. Yeah, so the proteinuria is a really good marker, but what you're saying is the rapidly progressive disease with this native function, and that's a recurrence factor afterwards. And then persistently elevated C3 NeF factors, or any of the NeF factors, they're all associated, and he's got all of them. So recurrence is a given for him. And so in that scenario, as we plan for transplantation, what therapy should we consider for this patient? Any thoughts, ideas? Some complement inhibitor, okay? Sorry. Rituximab, okay? So what are complement therapies out there under investigation? Because remember, nothing is FDA approved for C3G and nothing. interestingly, the KDOGI guidelines do say if you have C3GN and evidence of terminal complement-complement dysfunction, as in elevated CFAB9 levels, you could consider eculizumab. But that's a KDOGI guideline. None of them are FDA approved. What is out there right now, the phase 1 studies, EC is being studied for phase 1 along with the other 2. The phase 2 studies are all the other ones in the light green. And then the phase 3 are pegcetacoplan and iptacopan. Those are the 2 that are actively now in phase 3 trials. Iptacopan being the factor B, and then the pegcetacoplan being the C3 stabilizer. So this is sort of what we have. What do we do for this patient? And this is where I'd love your help to see if you would do something differently. So he received a living donor transplant, August of 2024. We did vaccinate him with all the encapsulated organisms, the 2 meningococcal, the Haemophilus and strep. We were able to get EC while he was hospitalized because our group did not feel comfortable putting an organ in him, knowing that the complement system was completely revved up. And so we did that, and he did well. But when we went to start doing that outpatient, after 4 weeks, we were denied. So we were left without any complement therapy. So our decision points when we started this is, should we transplant or not? And all of us felt we needed to. Should we transplant him standard of care or add EC? The whole group said we needed to add EC. And then when we came to now, we've gotten him to 4 weeks, and we can't do EC. What else do we do? Do we just not do anything and just wait to see if recurrence happens and then start treatment? Or do we try something? So we applied for compassionate use, and we were able to get a compassionate use therapy, so that patient is on it. In December, creatinine of 0.9, no proteinuria, hematuria, and on therapy, remember the C3 NeFs around? There's low-level tick-over or high-level tick-over that's still happening in these patients. So he gets acute influenza in January. The whole flu, seems like everybody's getting some sort of viral thing in Jan. So he develops new-onset microscopic proteinuria on therapy. We schedule him for a biopsy. He came to biopsy this week to clinic, and his proteinuria was gone because now he's over that acute phase. He still underwent a biopsy because it's 6 months, and we do a 6-month surveillance biopsy. But I'm going to pause here and ask you guys, in a case like this, what would you do, or what have you done? Or if you've had recurrence afterwards, what have you done? And what have been the challenges, more importantly? That's what you would do, Dr. Doshis, continue treatment outpatient? Yeah, so you're in our camp, we're too scared to not do anything. Okay. Yes, we were getting serial complement levels, and so the CH50 is suppressed, right? That's how we know that the EC is working. The CFAB9 level was okay, but the C3 was still low. Mm-hmm. Any other thoughts of if you would do something similar or differently? Yes, Dr. Gaston. Absolutely important question. So, why does it matter? I'll tell you. They were on thymo, antithymocyte globulin was the induction therapy, and then they got tacrolimus, mycophenolate, and prednisone. But why do you ask? So, idea of Rituxan to attack autoantibodies. So, Dr. Singh, would you like to speak to that? You thought about rituximab.
I have experience with just few patients. I have loud voice, so I think. But something like ACTHL, has been
ACTH analog.
ACTH analogs, you can try that. You can try, I don't know, what was the creatinine? Creatinine is 0.9 post-transplant. You can try more aggressive immunosuppression to keep those antibody levels down.
Yeah, yeah. So thank you for reminding us that Dr. Singh brought up rituximab, and thank you for bringing that up earlier in the conversation. Yeah, rituximab, we considered it, and we looked at the native C3GN literature, especially in patients who had C3 NeFs or C4, C5 NeFs. And it turns out rituximab in the traditional use of a gram and 4 rounds of it did not have meaningful reduction in these antibody levels. So that's why we chose not to do it, because it was so close to transplant and we were going forward. I don't know what you would do if you were in the native phase and you picked it up quite early. But our GN clinic, our rare GN clinic folks are moving away from using that. But it's definitely a thought. You know, it's an autoantibody, so can you use that to reduce the production of it? Yeah, and there's maybe in the future a role for that, yeah. Right. And we've sort of, from the bortezomib or any other B-cell therapies, we've sort of learning from at least the anti-HLA antibody response that the durability of those responses is pretty poor. And if you're going to have a durable response, it comes at a very hefty dose. Yeah, but these are all things to consider for this particular patient, absolutely. Right, I think that might be my last slide, because really what we were here today, and I actually would give a shout out to Apellis, because this talk was not meant to talk about pegcetacoplan. Talk was to talk about these diseases are hard. We will periodically see them. By the way, does anybody know the prevalence of C3GN? It's a rare disease, so rare disease defined as 1 to 3 per million US population. Anybody know what the US population is right now? Yeah, close, 346. So 346, let's just say times 3, it's still a little over 1,000 cases. So this is not common, it's a rare disease. And but already in this room, and we have what's the count, 50 people in the room? Maybe a little bit above, and we had at least 8 people in the last 2 years that had a case of C3, so this crowd is enriched for it. Part of it is that you came for this talk, but part of it is you're also in the transplant field that takes care of C3GN patients. So it's a rare disease. Eventually we'll encounter it. It's a challenging disease. It's real, where there is potential for risk and recurrence. Has anybody in the audience had a patient? Has anybody in the audience had a patient when they've had C3GN after transplant, recurrent C3GN? Yeah, we've had 3 hands. Sam, can we start at the back, and sort of if you could share your experience with what kind of case it was and what you did for them?
Hello, Gina Barletta from OHSU. I do pediatric kidney transplant. So this was a young man that had gotten transplanted prior to my arrival at the center. He had C3 disease. He had dense deposit disease going into transplant. When I joined the group, he was already about 2 years out from his transplant, but he had significant proteinuria. I biopsied him. He has recurrent disease, so I was able to get compassionate use for him, and his proteinuria is really stabilized. I have a question about the ability going into transplant, because I have another child I'm seeing next week who has C3 and is coming in for their evaluation. In organizing things for their transplant, is there a way to just start the process for the compassionate use going into transplant, especially if we have the luxury of a living donor?
Absolutely. So 2-part question. Thank you again for sharing your patient experience, where patient number 1 had known disease, recurred afterwards. You picked it up on surveillance biopsies, and then you instituted therapy. And then your question was, in planning for transplants like this a priori, knowing what we know now compared to back when we were evaluating this patient, would you start the compassionate use process earlier? The answer is absolutely yes. Both the phase 3 studies have online their compassionate use programs or protocols, and we just sort of applied. I will just, in full disclosure, tell you iptacopan is what we ended up using, because that's what we got first, and we had a bit of a timeline issue, so that's sort of where we went with, yeah. There was another hand up here, and then a hand up here.
I mean, for me, this was something I saw during my fellowship training almost 10 years ago. And this was a recurrent C3 nephropathy after transplant. The patient was already, by the time we were seeing, was on the third kidney transplant.
Third? Wow.
At that point. So I know that, I mean, I didn't follow up since I finished fellowship, but I know we had the patient on eculizumab. If there's any takeaway from this, I don't know if this knowledge of response to eculizumab, I don't think it was available at that time for us to know who is going to respond, who is not going to respond. And I think that's probably the big addition with respect to knowledge.
Well, thank you for sharing that. So first of all, a third transplant with C3GN. So in the days moving forward, if we have these complement therapies approved, hopefully we could control the process with the first transplant and not have the need for the second or third. We can hope for that world. And then what you said was, with being here, there was some degree of knowledge you gained from the different complement therapies that can be used moving forward. So yeah, absolutely. Thank you for sharing that. Two to 3 years, wow. So 2 patients used ACT in one, didn't work, rituximab in the other, ultimately both succumbed to other complications that our transplant patients sometimes get, BK infections, COVID, yeah. Thank you for sharing that. There's a hand in the back, and then another hand, and then we'll come to you, Dr. Doshi. Thank you. Yes, go ahead. Yeah.
Yeah, similar kind of story, young patient, C3G, and at that time, this was 2022, going into 2023, on eculizumab transplanted using mother's kidney, and then developed BK viremia, which actually ended up, that's how he lost his graft. I don't know, but, he had C3 deposits on the biopsy as well, but then reporting BK viremia. So I think in the scheme, like, people are talking, these infections, how do we control our baseline immune suppression while giving these C3, C5 therapies, and
Sure.
what is right? Because it's not just about preventing the recurrence. If this
Sure.
BK and all this happens, how do we,
Yeah.
what do we
So
do? And
your question was, you have a patient, you had him on therapy, and you paid the patient's graft paid the price with the BK viremia and ultimately lost that graft. So how do you control them? So what I can, and I'd love to hear from other people in the audience. I can only speak from the 2 experiences we have. We have a fair number of patients that have atypical HUS that after transplant we maintain on on complement therapy, complement inhibitor therapy, and at least being cognizant of the fact that they could be at risk for higher immunosuppression, over immunosuppression and infections. We actually maintain their tacrolimus and mycophenolate levels very modest. So even in my incompatible high-risk patients, in the first month, it's 8 to 10 TAC nanogram per ml trough level. And then by 3 months, I'm down to 6 nanograms per ml on that and keep them above that as much as possible. So I apply the same, get them through that acute phase, but then reduce and don't reduce too much. That sort of has been our strategy. And we have about, I want to say 13 patients right now. And we haven't necessarily seen a increased incidence of opportunistic or over immunosuppression related infections in that subgroup compared to our non-complement inhibitor therapy patients. But maybe the 14th one will have it. Yeah, but it's work in progress, so it's a great question, yeah. Couple more hands. Dr. Doshi, you have... Okay, yeah.
I have a question, Dr. Kumar. Do we have any nephritic factors checked again, or those nephritic factors are gone, or they're still there? The C3-NeF, C4-NeF for this
We
patient?
haven't done a functional analysis again on this patient because they've been on therapy now for a bit. We probably should. Every time we send some of this testing off, we're also spending a lot of money. So we're just using C3 as a surrogate, which is an in-house test. But if there was any change in his function, and we had to reassess our intervention, that will be the time to regather all the data. But you're right. I mean, it will be of huge interest to know what is happening on these, with all the other immunosuppression we've given him. Did we reduce the levels of any of these other NeF factors? It's sort of like the HLA antibody story. If they were there pre-existing, will they go away or not after traditional immunosuppression? I don't know the answer to that. It's a good question.
I want to ask another question. So if this biopsy shows C3GN again, what is going to be our treatment strategy? Are we going to inhibit the complement and a little bit higher up? Or what's going to be our...
The answer is I don't know, and I'm hoping, Dr. Akulok, as you start your journey after your fellowship, you'll come back and be giving this talk in 5 years and telling us what we should be doing. Absolutely. Yeah. Yeah, it's a great question.
So, hey, Vanita.
Yes.
That's it.
Am I
Dr.
hearing?
Kumar, that was a
Yes.
great talk. I don't have a case to share, but just asking, what happens in the native kidney world? What do they do for a patient who's not so end stage, who's diagnosed with C3GN? What is the treatment? Because we could perhaps learn from them.
So these phase 3 studies are what's there in the native world too. They're all awaiting FDA approval.
Got
When
it.
that happens, then it'll trickle down to our world too.
Correct. So maybe we can use this in your patient if
Absolutely.
this is a young person with a living donor transplant.
And both the phase 3 studies have been done in native and transplant patients. And there's data on proteinuria reduction. There's data on C3 deposits in the biopsy. So I definitely encourage you to look at some of these results. But they're very promising, definitely.
Perfect.
And GFR stabilization. So
Thank
yes,
you.
absolutely. No, thank you for asking. All right, what other comments or questions do you have before we stop holding you hostage and let you go? Yes, Dr. Srilekha, please. Sorry?
Yes. If you have a living related versus living unrelated donor, what's your approach?
So in this particular case, because it's because the C3GN and there was no genetic driver, in the absence of that, I would use the donor that would be the most suitable for this recipient.
Okay.
So probably somebody who is age matched, and some of it is like who comes in the door first and who gets approved first, that type of thing too.
Okay.
But if there was a genetic driver, then it would be in consideration that.
You'll go for an unrelated donor.
Yeah, then
Okay.
I would consider unrelated, absolutely, yeah.
Would you ever consider like plasma exchange before, if they have like high enough levels of nephritic factors?
So, your great question, would we do plasma exchange before we introduce the organ in them? So learning from our incompatible world, most of these antibodies come back if you're only going to do plasma exchange because the durability of response to therapy is just less than 48 hours. Yes, after doing plasma exchange, low-dose IVIG, we introduce all this immunosuppression, so perhaps those levels will go down. But it's not something that's been attempted. It's in a living donor scenario, just doing that as an isolated thing would make me a little uncomfortable, but it's a really interesting strategy to consider. Absolutely, yeah. Yes.
So if this was, we found a genetic abnormality, like in atypical HUS, there's consideration of simultaneous liver transplantation. Has that been looked at with, C3GN?
So right now, great question. Your question was if there is an evidence of some sort of genetic driver, would you then consider a combined liver kidney transplant? So at the present time, the only SLK genetic condition that I know that has an indication is the patients with the primary hyperoxaluria and oxalate nephropathy. So outside of that, there isn't sort of enough evidence or enough body of literature. So I would not be able to convince our team to consider a liver in that scenario. But as this field evolves and our understanding evolves, if we think this is something to do with being able to supply a healthy liver that'll then make up for enough of the complement, is it sort of a low production issue or is it a consumption issue? It appears to be a consumptive process and a destructive process. So you have got to take care of the things that are activating the C3 and consuming it. So perhaps a liver may not be enough is what I would postulate.
Fair enough. Thank you.
Yeah. All right, we're coming up on the hour. I am definitely around. Thank you for your attention, for coming. And I'm here to answer questions, but I don't want to hold you guys hostage. Thank you.